So now we have to move to the next speaker, and of course for me it's a very big pleasure to introduce Dr. Roberto Valcavi. Of course everyone knows him. We have to say, all of us, thank you, because thanks to him we are here. And in particular I have to say thank you for this invitation, and also because Roberto is also one of my mentors, especially in this topic. He is going to talk about ethanol and thermal ablation of thyroid cystic lesions. So please, Roberto.
My presentation today will focus on ethanol and thermal ablation of thyroid cystic lesions. Ethanol has been the first agent to be proposed and used for thyroid ablation. Soon it was clear that ethanol is indicated in thyroid cystic rather than in solid thyroid nodules. The mechanisms of ethanol tissue ablation are directive coagulative necrosis, local small vessel thrombosis, and eventual tissue sclerosis. This image shows a partially septated cyst in the usual axial position in front of the patient. Fine needle aspirates are always obtained from the solid part of the pseudocyst, or cyst, if you want to call it cyst, in order to get cellular material. It's not worth to get material from here, but you pick up material from there. All patients should have benign thyroid cytology before procedure, before ablation. The patients and the image, the image is overturned. It is the same image of the right lobe. It seems a left lobe, because the patient, I sat behind the patient, and I found that this is the most comfortable position, provided that you have the ultrasound monitor and the repeating monitor in front of you. And this is the position that I prefer for all interventional maneuver. And I will show you later the exact position. With the power color Doppler, you saw the snowfall effect, indicating there is refractive colloid inside the pseudocyst. Again, I will stress that painless procedures are preferred, are by far preferred by our patients. This is why I suggest performing a minimal 2% lidocaine anesthesia in ethanol ablation too, because, and of course, skin disinfection is also important. And this is the list, the checklist that I use before doing ethanol ablation. First, ascertain no allergy to lidocaine, and carefully disinfect skin with alcoholic neoxidine. And it's a tip that I give to you. The disinfecting agent is used to couple the probe with skin. So you don't need sterile gel as a cupping agent, which makes a mess. A sterile cover coupled with the probe with gel protects the probe. And local anesthesia in ethanol provides no pain during cannula needle. I use a cannula needle. I will show you in a few slides, insertion, and when it is withdrawn. Especially at cannula needle removal, a drop of alcohol may leak in the subcutaneous tissue, which may cause transient but severe pain, which is not good for patients. So I was sitting behind the patient with a transseismic approach. In the case of a right thyroid cyst, this is a right thyroid cyst, I hold the probe with the right hand and the needle and the syringe with the left hand. You must invert the use of your hands, and you have to teach yourself to use both hands to do maneuvers. A thin 27 gauge needle is then inserted exactly where Gilles said, between the capsule and the fascia, and just a few drops of local anesthetic are given. And a venous plastic cannula is then inserted. I use a cannula rather than a standard steel needle because once the cannula is placed and the stylet is withdrawn, there is no risk to move the needle from part to part of the cyst, which could happen especially if the patient would swallow. A three-way Luer lock stopcock with tubing is then connected to the cannula. There are two syringes, two Terumo, I prefer Terumo syringes, two 20 ml syringes. One is there with 95% alcohol, sterile alcohol, and the other is used for drainage. Drainage should be done carefully in order to avoid former hemorrhage. Extracting the fluid blindly is particularly important for avoiding hemorrhage. And this part of the video shows the insertion, as seen by ultrasound, the insertion of the needle cannula, and after placement of the cannula in the center of the cyst, the stylet is withdrawn. Here it is withdrawn, and the stopcock Luer lock 3 ways is connected. And then you can see in these images clear the cannula, which doesn't hurt, and you don't have to worry to transpass the lesion. And I try to have a complete drainage of the cyst at variance with some others who recommend using the standard steel, would recommend to leave some fluid inside. And then the cyst is washed several times with alcohol until clear fluid is, yes, this is the assistant, and now clear fluid is obtained. You will see now the images by ultrasound and the classic, the typical hyperechoic signal. Only a small amount of alcohol is left behind in order to avoid adhesions. So this is the same case 1 month after ethanol ablation. The vast majority of the cyst was ablated, and it was transformed into scarring tissue, which is the darkest part. Yet some thyroid parenchyma tissue was not destroyed, and here you see some parenchyma tissue which was not destroyed, and some fluid remained inside. The volume reduction was good, but it was not enough satisfying for me. And I show you the technique, other techniques that could be used. And this is the ideal antibody cystic thyroid nodule for percutaneous ethanol injection. Pre-treatment volume was about 7.6 mL, and you see over the time what happens. Only a small scar tissue is left behind, So I would say this is the ideal patients to have ethanol treatment. It is not really the same with the majority of cysts which are mixed thyroid nodules. And in this case, after treatment, 12 months after treatment, the volume reduced by 76%, which is not bad, but I was not totally satisfied. The patient maybe was. This is an old study published with Dr. Fasoldati as early as in 2004 in 266 patients, and comparing ethanol injection to simple drainage. So there is no story that ethanol ablation was more effective, 85.6% in overall patients volume reduction rate versus 7.3%. And we examined the same patients, and maybe there is Dr. Pesenti who made these slides several years ago inside. Marilla, are you here? Yes, Marilla. Make a question after that. So we split the population into two subpopulation, antibody cysts versus mixed cysts. And you clearly see 90%, almost 90% reduction with ethanol. And in mixed cysts, 65.8% volume reduction. And these are ethanol ablation has been introduced a few years ago, both in AACE, AME thyroid nodule guidelines, as it was mentioned this morning by Dr. Andrioli, and in ATA thyroid nodule guidelines. The strength of recommendation is, however, different. There is more strength in AACE due to the Italian influence, I believe, AME thyroid nodule guidelines. I was a co-author of these guidelines, and so there is good evidence of percutaneous ethanol injection as a safe, effective outpatient therapy for thyroid cysts. And of course, the same as said before, you should carefully sample the solid component of the lesions before performing PI. And in this guideline, PI is recommended as the first line treatment for relapsing benign thyroid lesion, cystic lesion that we saw are the vast majority of lesions. Most of them, if you drain only, will relapse. PI, as I already stated, is not recommended for solid nodules. And in the 2015 ATI thyroid nodule guidelines, there is still a role for surgery, so there is less strength in this. I see less strength in these guidelines for ethanol injection. But I saw that most of you perform it. So eventually, after a few years, ethanol injection was adopted by many doctors, by many endocrinologists or interventional radiologists. I don't believe by many surgeons. Again, asymptomatic cystic nodules may be followed conservatively. So the question now is, in thyroid cysts, is ethanol ablation itself always adequate? And what about the thyroid parenchyma tissue component? What is the role of thermal ablation in the treatment of thyroid cystic lesions? And this is a paper published recently by Professor Beck and co-workers, who proposed the combination of ethanol ablation and radiofrequency. He reported two cases: a 65-year-old woman with a right thyroid nodule. In this case, in the first instance, panel A, it was performed, mostly cystic lesion, was performed ethanol ablation, but after 3 years, the lesion recurred, and the patient was simply treated with radiofrequency successfully, as you may see in the panel in panel D. And in this second case, Professor Beck used a different technique. This was a mainly cystic or pseudocystic thyroid nodule with a fluid component, but after drainage, he observed bleeding inside and treated with with ethanol the patient, and after ethanol, radiofrequency. The eventual result in panel D is the permanent cure of the patient. So it's interesting, and I will show you a video in which I used the laser for a large complex thyroid cyst, which was septated. This is a true septum, and this is the needle. And okay, it starts. It was gently, in the first instance, the cyst, the lower, the medial component was drained with a G21 needle used, the same used for the laser ablation. And after that, the needle was repositioned, and it was drained, the second part of the cyst, or the pseudocyst. And the laser, then the fiber was inserted into the needle, and the laser was fired. And this is laser firing. And these are the results 3 months only after laser ablation. We observed a clear reduction that the cyst was within the frame of the thyroid, and we had a 92.6% volume reduction rate with this treatment. So, in conclusion, ethanol ablation, or PEI, ensures good outcomes in antibody cysts. So they are candidates. Cystic thyroid nodules are almost always pseudocystic thyroid nodules with a variable parenchyma tissue component. A thyroid parenchyma portion remains not ablated by the ethanol in most pseudocystic thyroid nodules. Therefore, combining thermal ablation with RFA and ethanol, or performing a laser ablation, may be more effective than ethanol alone in pseudocystic lesions. In conclusion, ethanol ablation is ideal in antibody cysts, but does not ensure a complete ablation in mixed cysts. After thyroid pseudocyst drainage, combination of thermal techniques such RFA or RFA plus ethanol ablation or laser ablation could be new effective approaches for thyroid pseudocyst treatment with a thyroid parenchyma component. Thank you.
Thank you, Roberto, for this excellent presentation. So I wonder if there are questions from the audience, please.
Richard Hardy, United States. I enjoy your talk very much. In researching types of pure ethanol that are available for purchase, in the United States, there's one that's called dehydrated, USP certified, meaning it's certified for actually use in intrathecal and intravascular catheters. And there's also a 200% 200 proof ethanol, which is approved for industrial use. And I was wondering which type of alcohol is appropriate for this, because the other type, the USP appropriate for intravascular injection, is about $185 for 5 cc's.
Well, thank you for your question. I don't have experience with different percentage. I always used 95, and I think that is the vast majority of the audience will use the 95% ethanol injection. Thank you for your observation. Thank you.
Thank you, Dr. Valcani. I have 2 questions. One, is there any head-to-head study between putting alcohol and draining the alcohol versus just put alcohol 1/3 of the volume and leave the alcohol inside of the nodule?
As far as I know, no. There are different techniques. I recommend my techniques because it's effective. You don't leave, well, the problem with leaving some ethanol inside are adhesions. If after a while it happens that the patient is a candidate for surgery, the surgeon will bless you because of adhesions, especially in cysts which extends to the laryngeal nerve. So I would recommend to wash out many times until the fluid is clear, and this is my technique.
Thank you. The second question is, how often you have a very dense colloid nodule that you cannot remove, and you have to use the San Gennaro procedure?
Yes,
I'm
yes,
not Napolitano.
Yeah, that's a good question. In some cases, you cannot drain with a 21 gauge, not even with a 14 gauge needle. And in these cases, I try to drain as much as possible with the largest needle available, which is the 14 gauge, and to put inside some ethanol. And after 1 week, the colloid will melt. But in this regard, I believe the microwaves may have new developments in this particular setting, which is sometimes very difficult to treat. The San Gennaro means that you must have a patient coming not from the other part of the world. Sometimes it happens to me to treat patients coming from the other part of the world, and it's difficult to take them, to have them for a week or a month. That is the time that you need to have the San Gennaro effect. But it works. If you take a colloid, and put alcohol in a tube, you will see the melting of colloid. An alternative may be microwave melting.
Priedīts, radiologist from Latvia. 2 practical questions. Sometimes, First, about amount of ethanol. Sometimes cysts are very large. My largest cyst is 400 milliliter.
400.
What to do?
Well, I didn't see any particular difference due to the extent of the cyst. First, you make sure that you drain the cyst. Drain all the cyst, not leave any fluid behind you. And second, wash the cyst several times, and this will ensure adhesion and sticking of the wall. And well, in my experience, I didn't ever treat a 200 milliliters cyst, but I treated, I remember, a 90 milliliter cyst, and it worked perfectly.
Thank you. Another question. Sometimes we see that immediately after the evacuation of fluid, cyst refill with blood.
Yeah.
Immediately. What to do?
Yeah. You should be carefully to avoid form a vacuum hemorrhage. It happens. Remember that the ethanol itself coagulate blood, provokes small vessel thrombosis. So my recommendation is, if you find this effect, you shouldn't drain. You should drain very gently and wash out several times until the fluid is clear.
Carmelo Barbaccia, otolaryngologist from Dubai. I can help you with hoarse voice later. Congratulations for the organization. My question is, as you mentioned, it's very important to do the fine needle aspiration before, of course. But when you do the fine needle aspiration, you empty completely the cyst, or you take only a sample. If you empty, of course, you are waiting the refill, and you are waiting before treating once time, twice. There is any rules to when to perform?
Well, your question was to
about
take
the
out,
fine needle aspiration.
to take out or to
take just a
drain
sample.
all the cyst.
From fine needle aspiration purpose.
Well, I do it in 2 times. Usually, I try to perform a fine needle aspirate. In the first instance, I have the patients come 2 times. So in the first instance, I perform fine needle aspirate, possibly in the parenchyma tissue. If not, you will have a Taiwan is realistic to have an insufficient sample if you take the fluid only, because you will find only macrophages and no thyroid cells. So in these cases, you must bet that this is not a cystic papillary tumor. Of course, it may happen, but papillary tumors, cystic papillary tumors, have always a parenchyma component. If you study the pseudocyst very carefully by ultrasound before performing procedure, I believe that I didn't make alcohol ablation to many tumors.
Roberto, just a question a little out of this topic. I usually do ethanol injection also in parathyroid cysts, but the literature is not so in agreement. What do you think about?
Yeah, good. In parathyroid cysts, ethanol may work. I have an experience in parathyroid cysts as well. The problem is with inferior parathyroid, which is very close to the laryngeal nerve. So laryngeal injury is quite, could be a problem in inferior parathyroid ethanol ablation. But provided that you stay inside and you drain the parathyroid exactly in the same way I showed, I do in thyroid cyst, it's good, and you totally cure patients. I agree with you, yeah.
Thank you, Dr. Valcavi.